be seated.
Hereby, I open this academic ceremony in which Stefanie De Smet will defend the academic thesis entitled Brain State Dependence of Prefrontal Non-Invasive Brain Stimulation, Insights and Clinical Implications. May I invite you to present a summary of your work and the conclusions of your thesis.
Okay, a very warm welcome everyone to my PG defense. During the next 15 minutes I will present some of the work I've been doing during the last couple of years. And I'd like to start off with a simple scenario. So imagine telling someone to just stay calm and relax. Now think about how this message lands when you tell that to someone who is already very calm versus if you would tell that to someone who is in a very stressed state. The exact same instruction can already have very different effects depending on the state that someone is in. And that is something that is very central to the work I will present today. And I will discuss this principle in the context of non-invasive brain stimulation, which is a technique which you can use to stimulate the brain from the outside, so without surgery. Just like the example I gave before, just doing brain stimulation, it's highly dependent on the functional state of the brain at the time of the intervention. And that is something we refer to as state dependency. In this thesis, we focused on state dependency of the frontal brain regions, which are located here. It's called the prefrontal cortex. And it's very important for things like attention, but also how we handle emotions and how we deal with stressful situations. And importantly, we see that in people with, for example, psychiatric disorders such as depression, there is abnormal activation in those regions. Now, in my thesis, I focused on two main techniques, one being magnetic stimulation, or repetitive transcranial magnetic stimulation, or RTMS. And here we use a magnetic coil that we place over the head, over the frontal area, to deliver brief magnetic pulses, thereby triggering brain activity. And a specific form I used in my thesis is called theta burst stimulation, or TBS, where these pulses are delivered in a very patterned rhythmic manner. Another form of stimulation I used is electrical stimulation, here depicted as transcranial direct current stimulation, or TDCS, where instead of using a magnetic coil, we place two electrodes over the head and then inject a low electrical current through those electrodes to stimulate the brain. So what this thesis aimed to do was look at the state dependency effects of those prefrontal brain stimulation techniques and thereby determine for when, how, and whom stimulation appears to be most effective. And we tried to study that in 5 different studies, 5 empirical chapters, each focusing on different aspects of state dependency and also different parameters. For instance, in chapter 2, we looked at an association between if stimulation effects are dependent on how engaged people are. In chapter 3, we focused on if being stressed can make you respond better to stimulation. And later we also look at overthinkers, people who overthink a lot. Do they respond differently to stimulation? And then in the final 2 chapters, we focus on if it matters if the brain has already been stimulated before. If we look at this, you could say that the first 3 chapters focus on something we will call psychological states. So being emotional states such as being stressed versus being calm, whereas the final 2 chapters focus on what we call stimulation history. So how stimulation effects depend on prior stimulation or stimulation that is given at the same time. So we start out with chapter 2, where we recruited 133 healthy volunteers and we assigned them to 2 different conditions. Half of them approximately received real electrical stimulation, real TDCS, and the other group received sham stimulation, which is kind of like fake stimulation. So half of them real stimulation, other half fake stimulation. And during stimulation, each of them did a task. They had to respond to squares, but also errors, but importantly, they were also showed emotional images. Here is a positive image, it's a puppy, but it could also be something negative like a snake or any other kind of emotional image. Now, after the TDCS and the task, we asked them to recall a negative event that happened in their life. So something negative that happened to them, and they had to recall it, write it down. And afterward, we asked them to reinterpret that, so make the event less negative, something we call reappraising. And we asked them to write that down, also measured some physiological recordings, such as their heart rate. And what is important here is that we saw that when people received real stimulation, they were actually better at reinterpreting this negative event, whereas this was not the case for the group who received the fake, the sham stimulation. And the key here for our state dependency story is that we see that the more emotional engagement people showed during the task, the better they were at reappraising or reinterpreting this event afterwards, but only for the people receiving real stimulation. So that was already hinting to a clear state dependency effect, and then set also the stage for our second chapter, where we focused on stress state and experimentally manipulated their state before they received stimulation. So as I said, we did that using stress. So we compared being stressed versus non-stress. I wouldn't say calm, but a non-stress state. And we induced stress using a paradigm where we asked participants to give a job interview, and they were being evaluated by two external members wearing white coats and didn't actually react to any of the signs of social interaction coming from the candidate. They were also being recorded with a video camera to maximize their stress response. And again, there was also control task, so similar setup, but without all the stressful elements. So we had a group of participants being stressed, another one not so much, and then we also divided them between giving them real stimulation again versus the sham or the fake stimulation. So 146 healthy volunteers divided into 4 groups, either being stressed or not, or either receiving sham stimulation or real stimulation. And the key takeaway from this is that we see that at a working memory performance after, they were actually better following real TDCS, but only if they were stressed before. So that answers our question that being stressed can actually make you respond better to stimulation in this case. And with this, we move from what we call more transient states, so states that can change over a relatively short amount of time, to more stable characteristics, for instance, how people tend to overthink. Some people rarely ever overthink, some can never stop doing it, and we wanted to see if they also respond differently to stimulation. So we recruited them to the lab, and here we move away from the electrical stimulation with the electrodes to magnetic stimulation, to the theta burst stimulation. And we divided them into 3 groups. Again, there was sham stimulation, so sham TBS, so the fake stimulation group, but also 2 types of real stimulation, one being intermittent theta burst stimulation and another one being continuous theta burst stimulation. And we recruited participants with different levels of overthinking. So some that rarely ever did, some that always do, and everything in between. And then again, we looked at how they responded to stress. So using the same paradigm as before with the job interview, and we assessed both their psychological responses, but also their physiological ones. The key takeaway here was related to cortisol. Cortisol is an important stress hormone which typically increases when we are confronted with something stressful. So if you follow the red line here, you can see it starts out flat, but then increases about 15 minutes after being confronted with the stress task, and then decreases again. So this is something we typically see. But what was an important finding is that we didn't see this for a particular real CTBS condition. So this typical stress-induced cortisol peak was actually not happening, but only in people who overthink a lot, which we call high ruminators. So it appears that for these high ruminators, this type of stimulation had a buffering effect. So that brings us to the final 2 chapters where we move away from these psychological states and talk about stimulation history. What if the brain has already been stimulated before? And we started out in chapter 5 with combining two different types of stimulation, being both electrical stimulation and magnetic stimulation. So we combined TDCS with data burst stimulation, and we literally applied the TBS coil on top of the left electrode, doing stimulation at the same time for an amount of time. Here, participants were invited twice to the lab, so there were two conditions, and they did each of them. So with 1 week in between, they came to the lab. And here we compared real electrical stimulation, real TDCS, to real theta burst stimulation versus a condition where they only received magnetic stimulation. So we really wanted to see if doing electrical stimulation on top of magnetic stimulation boosts the effects, let's say, of the magnetic stimulation itself. And again, we focused on stress. Here we used a different stress paradigm, one where there were alternating sessions of putting your hand into water of 2 degrees, which is rather cold, to get alternating with parts where they had to do an arithmetic task, again, also being video recorded at the same time. Importantly here, we didn't see any additional effects. So doing electricity in between the magnetic stimulation didn't add anything in terms of how they responded to stress. In fact, it actually led to more discomfort. So people receiving the combination, or no, they all received it, but the combination, so receiving the combination led to more self-reported discomfort compared to the magnetic stimulation on its own. So this discomfort made us think, and for then the next chapter we wanted to move in a way of combining this magnet on the electrodes, and we then focused on doing magnetic stimulation twice, and instead of doing it concurrently, we did it in a sequential order, where we first applied theta burst stimulation, something we call a primer, let's say. We waited for 15 minutes, and we did another session, which we refer to as our test protocol. So this is a concept we refer to as priming, where one stimulation session is followed by the other, and the primer is supposed to boost the effects, let's say, of the test protocol. Again, a bunch of healthy volunteers. There were 4 conditions, and again, a single participant did each of the conditions, so they came to the lab 4 times. Here there was a control condition, so fake stimulation the first time, fake stimulation the second time, versus single stimulation, fake stimulation the first time, so the fake primer, then real stimulation the second time, and then the final 2 conditions were twice real stimulation, but we alternated with giving same stimulation twice versus giving opposite stimulation first. So ITBS is the same type of protocol that we basically repeat 2 times, and in the final one, CTBS is supposed to have more opposite effects than ITBS, so this was also expected then to boost the effects of the second stimulation, let's say. Here we focused on functional brain imaging, so we literally put people into the scanner, both before and after the stimulation protocols, and looked how their brain regions were connected with each other at rest. So let's say how well they communicate with each other. And these are the results. So the green circle you can see is actually where we placed the coil on the head, and it's the center of the coil. And it was also the region we were looking at, how well it was connected to the other regions in the brain. And the yellow-orange blobs you can see were the regions that actually popped up, that showed connectivity differences with that spot we were looking at. And what you can see is that it's actually happening right under the coil, so right where we stimulated, but also more towards the back, temporal regions, and to the entire back of the brain, the occipital regions. Now, what was important here, like I said before, we expected this to give like a boosting effect, but in fact, we found a reduction in connectivity. So you could say that regions were communicating less well with each other following the priming conditions. So that gives me an overview. So for the first 3 chapters are more or less in favor of psychological state effects that shape outcomes. And for the final 2 chapters where we looked at stimulation history, the evidence is a bit more mixed. We didn't find any evidence when combining electrical with magnetic stimulation. And we did find significant things when doing theta burst stimulation twice, but it was in the opposite direction of what we expected to. And with this, I want to give you my main takeaway. It's clear that for stimulation, no one size fits all. Stimulation effects really depend on the person, but also the state they're in and how stimulation is applied. Thank you.
Well, thank you for your presentation. On time, on the second. Thank you. And so now the opposition will be opened by Professor Schumann, who holds a chair in the clinical applications of non-invasive brain stimulation. The floor is yours.
Thank you, Pro-Rector. Dear candidate, let me start off with congratulating you on a really nice thesis. Thick book. It was very nice to read. I was quite impressed. I saw that you already published 4 of your 5 chapters, and looking at your CV on how much you've already published throughout your PhD, yes, I was very impressed. I also really enjoyed your presentations, and I would like to extend my congratulations, of course, to your promoter team, and well done. I also have a question, of course, and I'd like to start off with chapter 4. So, as you were just showing in chapter 4, you investigated whether the effects of excitatory and inhibitory TBS actually have an effect on stress reactivity and whether that effect depends on trait rumination. In your introduction there, you state that individuals who are high in trait rumination actually tend to show reduced left DLP activation during emotional regulation tasks. In your hypothesis, then you write, we expect that the effects of ITBS and CTBS would be more pronounced in individuals with higher levels of trait rumination. And that bit I don't understand. So if you say there is less activity in the left DLPFC, I could probably understand that you see more effects if you give ITBS rather than CTBS in these individuals. But why would you expect more reactivity in those for both stimulation protocols?
Okay. Highly esteemed opponents, thank you for your kind words and your question. The main reason we assume that having individuals with trait rumination might respond more strongly, let's say, is for the mere reason of expecting them to have more room for improvement. When we stimulate healthy individuals, we're trying to change a system which is supposed to be already working quite okay. And in these individuals, the system is working suboptimally. So applying stimulation to those regions, I think it leaves to more room for improvement, let's say. Also in terms of stress regulation. So for ITBS, that we expected to see, or there was a higher chance of seeing that the ITBS stimulation would result hypothetically, of course, because results were different, in stress-induced changes that were decreased. Whereas in CTBS, we expect that it would be exaggerated, but based, of course, on prior literature that showed similar findings using these protocols in healthy individuals.
Mm-hmm. So I understand your argumentation for the ITBS, because the activity isn't there. We give a protocol ideally that enhances the activity there. So I would say there's more room. So I could actually see more there. But if we inhibit an area that is already more inhibited compared to the other group, I wouldn't understand why they would show more, or why you would expect more reactivity there.
I think the idea was that the more prefrontal activation, the better their stress response would be. So the more inhibition they would show, the worse it would be. So also the worse reactivity we would see.
Okay. So in a way, or maybe I misunderstand it, but in a way it doesn't matter how we stimulate, but they will always react more extremely, no matter whether we do an inhibitory or an excitatory.
That was what we assumed, but I think our findings clearly show that it doesn't. So it was an oversimplification of what we expected, and it's clearly because it was the inhibition that actually gave the good effects. Mm-hmm. So indeed, in our but it were our hypotheses a priori, so we had to stick with them, of course. Mm-hmm. But I think for prior research, this is clearly an oversimplification, and we have to look at this differently.
Okay, good. That's very clear. And then just a few days ago, I was at a PhD defense here of Amoury, who you probably know, and she had a whole PhD about when you have depressive patients, that maybe left DLPFC stimulation might not be the best stimulation site, because lateral OFC stimulation might work much better, especially in patients who ruminate. So she had a very clear message: ask your patients what their main problems. If they ruminate, go for orbitofrontal cortex. You, however, only study left DL PFC. I would wonder what your thoughts are about this and about the clinical translation of your findings.
Yeah, I think what you're touching upon is that we all study different parameters in isolation, of course, whereas I focused on context and state as being an important parameters. What we typically see in the field is indeed that people play around, let's say, with location. And indeed, it can be that for people with high rumination levels, orbitofrontal stimulation might be more appropriate, but that can also be independently of context. So I think these are findings that don't necessarily contradict each other. They can stand next to each other, and there's all different parameters we have to look at, and at some point see how we can merge them to make simulation most effective.
So if you were to do your entire experiment, but now with OFC stimulation, what would you expect to find then?
I think hypothesis why, knowing the findings we have now, probably that if we stimulate orbitofrontal, you mean?
Yes.
Right. Yeah. That perhaps effects might be better, but it's hard to tell because if you don't compare it to DLPFC stimulation directly with the setup we use, I think, if I'm not mistaken, her techniques were using TMS. So it also depends on the stimulation technique, how well we can target the region we're interested in. But based on those findings, you could argue that an electrical setup targeting that region might be more effective, but I think more research would need to show a direct comparison to validate it.
I'll give the word back to the pro-rector.
Thank you for your questions. Your position will now be continued by Dr. Nathalie Michels, who is a postdoctoral fellow at Ghent University with expertise in psychophysiology and public health. The floor is yours.
Thank you. Dear candidate, thank you for your crystal clear presentation. Again, reflecting your excellent work and 5 nice studies, well controlled. I will start with a question on the methodology, because if I compare your different studies, I see that the psychophysiological markers that you use differ and depending on the study. So for future studies that want to examine your topic further in detail, which psychophysiological measures would you certainly recommend, and which would be a nice add-on to give more information?
Dear esteemed opponent, thank you for your kind words and for your question. Bold answer, depends on the budget, I'm afraid. Yes, I would love to integrate cortisol in all my studies, but in fact, in only 1 out of 4 there was budget to do so. So that's the reason it was only that one. But based on the literature and the hypothesis around the effects of TBS on depressive symptoms being related to your APA axis regulation, I would definitely consider adding cortisol in future studies. If there's budget, second best would then be heart rate variability. Also because of important literature around that, about frontovagal pathways affecting also TMS effects. There's a whole line of research saying that if you based on your heart rate and rather the decrease in heart rate, that you know that you target the right spot, let's say. So I would definitely consider those. And I think we also added electrodermal activity and blood pressure. I think usually there are easy measures, low-cost measures to add to your study that also can help you find differences between sympathetic, parasympathetic activation. So that would be my number 3, but definitely cortisol and heart rate and HRV.
Okay, thank you. Indeed, budget is always an important part. You mentioned HRV, and it brings me a little bit outside of your topic, maybe, I mean, your main expertise. I know that in the research field that you're working, another approach is slow-paced breathing. That is now examined and more used because it's targeting the HRV. In which way is it targeting a similar way, like your brain stimulation, or is it really a complementary perspective? What is already known about the different mechanisms of these different approaches?
With slope-based breathing, you mean specifically?
Yes, indeed.
In fact, that's an interesting topic that one of my supervisors is highly interested in. We actually did a combination of slope-based breathing and the electrical stimulation I used in the thesis, TDCS stimulation in Ghent already. Here we compared regular breathing to slope-based breathing and then real and sham TDCS. And where we found very strong effects of slope-based breathing, we didn't see any additional effects of the TDCS, unfortunately. Though I do think that body states like breathing can be very important. It's also a state, of course, that can impact how we respond to stimulation. And I'm wondering, though, if the null effects we found, if it could be related to the synchronization, let's say. Would it be different if we stimulate at a certain part of the brain wave, let's say? Could that be different? I think there are some studies already looking into that, but very limited. So I think more research would need to be done there to help untangle that, but I think it's definitely something to look into. A body state is even as important, let's say, as a psychological state.
Yeah. Okay. Then I will go towards implications and the type of population that we want to target. And so, of course, your focus is towards mental issues, and your implications are translated towards clinical populations. Of course, you tested it in healthy populations. So my question would be, with the current knowledge that we have, this type of intervention, would it be mainly interesting as a treatment, and so when the clinical symptoms are really there, or more as a prevention? And so when people already have some issues, and for example, people high rumination, then it would be helpful to prevent further exacerbation towards depression, for example.
Interesting question. I think we need to consider context, even if it's research or clinic, no matter what, because we often see that people ignore it. They only focus on one parameter. In terms of it would be interesting for prevention, possibly. It worked here in healthy volunteers with only high rumination levels, so subclinical samples can show effects for sure. We also saw effects in the other samples where we didn't focus on high rumination. In terms of prevention, I think it's interesting and it would be something we could do. I think the only pitfall there is the reimbursement and the companies allowing us to apply the stimulation to non-clinical applications outside of research.
Yeah, so that's the main issue still to apply it as a prevention. Okay, then my last question. When I looked at your excellent CV, I've seen that you also got to know more about another technique, the functional near-infrared spectroscopy. In which way would this technique be helpful to get more insights in the types of studies that you have done?
Yeah, FNIRS is really interesting because a bit similar to EEG, it's considered more low cost than MRI device for sure. And I think more and more people are looking into those techniques, how they can find biomarkers using those techniques instead of using an expensive fMRI device to make it more translatable to the clinic for that reason. And it's becoming more and more popular. You're not, of course, not able to find activity in deeper regions. But I know we're doing a study with FNIRS in Ghent too, without simulation for now, but using emotion regulation and criticism to already see how much activation we can capture using FNIRS. And I think in Maastricht they're also combining FNIRS with stimulation already, so it's a rising method for sure. But yeah, a lot of more work needs to be done in that area.
Yeah, especially because it's difficult to target the deeper regions then.
Yeah, and
okay.
Yeah,
you can further elaborate if you had still some thoughts about that.
If there's time left.
I actually think that the elaboration will be for some other time.
Okay, perfect. Thank you.
Thank you.
Thank you, Dr. Michels, for your questions. And I would like to offer now Professor Oshie to ask questions. She holds a chair. Actually,
no chair.
You can help.
Not yet.
No? But you're at Oxford University, and actually I'm somehow missing the chair or the expertise that I should you announce you with. Maybe you can complete the situation. Your expertise is?
So I'm an associate professor and I work on non-invasive brain stimulation and brain plasticity and mental health.
Thank you. The floor is yours.
Thank you very much. Dear candidate, I would like to echo some of the previous opponents to really warmly congratulate you on what's a really impressive body of work. I think the creativity of your studies, the complexity of them, the sample sizes, and also the sophistication of your analysis really stood out to me compared to many other theses that I've seen. So strong congratulations to you and also to your promoter team. So my first, we have interacted quite a bit previously in the Ghent internal defence, and I had some technical questions, so I don't have any technical questions today. My questions are just a bit more general. So given all this work that you've done over the last 5 years, you've obviously learned a lot about what works and what doesn't work with stimulation. So I'm curious, if you were starting your lab with your first PhD student who was going to build on this body of work, asking similar questions, I'm curious what now, given the knowledge you have, what would you do differently and why?
Highly esteemed opponent, thank you for your kind words and for your question. I would love to continue working with subclinical or clinical populations, because if brain states matter so much, then it's clear that in healthy volunteers we only have limited information from the studies we do. And I think based on the thesis, we could continue with people who overthink a lot and actually look further than diagnosis, being depression or OCD or whatever kind of diagnosis, and focus on more cognitive effective neurobiological things such as overthinking and ruminating. And then continue in studies, doing studies in those individuals. And I think an important thing could be in the future to look at timing also. So, for example, neural oscillations, using EEG, or like with the resonance breathing, looking at breathing, and then what does timing do if we simulate at a certain time in these people with subclinical symptoms at different times? Do we see different effects? Because this will also be something we can implement in the clinic, but also in terms of inter-individual differences. I still always examine now group level differences, and I wonder if we could find something, being a simple questionnaire or a physiological marker like HRV or cortisol beforehand, that would determine if someone would respond better to different types of simulation. That would also be a very interesting avenue to go, because I think it's very interesting in the clinic that we have something like that doesn't ask too much from the clinician to implement. So I think those would be roads I would take and hopefully will take.
So really interesting ideas for clinical application. If I was to ask you to switch your focus back to your thesis and the experiments that you did, and if I was to say, okay, you need to bet financially with your lab's limited funds on which of these studies is likely to replicate, and you're going to have to commit to it in a pre-registration, I'm curious which parts of your work would you bet on replicating, and which bits do you think maybe less likely to replicate?
I think the clear evidence came from psychological states. So I think it would be, or at least it's clear that we need to move towards doing studies also in terms of replication where we do something during stimulation. As for the final 2 chapters, there might have been a lot of noise by doing it at rest. We do TDCS stimulation at rest. They might have been ruminating. They might have been thinking about the holiday. You don't know. That could have affected their responses, leading to null results. Also the combination, doing theta burst simulation twice, there was a reduction, but what does it really mean? They could have been doing anything or thinking anything. So I think from there, I wouldn't replicate. I think those are less easy to replicate, and I wouldn't either. I would think there, for those chapters, I would focus on timing in between. So because that seems to be like an important aspect. We did 15 minutes in between. It appears from the literature that more time in between might be more important. But then again, I don't think I would keep continuing with doing stimulation at rest, because it's very clear from the first 3 chapters that it matters, that we do something during the task. And if I would have to replicate one study, I think I would love to replicate the third one, not because I enjoy stressing people, although I know some of my colleagues and even my husband was an evaluator at some point. I thought they thought it was fun, but I think it's an important study. And yeah.
So that is the working memory study, is that right? Yeah. Okay. Nice.
So yeah.
Great. So my last question is maybe a bit more of a philosophical question. So you argue in your thesis, and you accurately reflect the literature in your argument that to treat depression, it's important to increase cognitive control over emotional states. But I sometimes wonder about that, whether learning or sort of teaching people to essentially suppress their emotions, it might be quite good short term, it might make them more functional, but whether it's reducing symptoms rather than really tackling the core emotional dysfunction that may be driving things. And I wonder whether it might be related to recurrence and relapse rates, which of course are high with depression. So I'm curious what you think about that, because that really is the strategy for most of this TMS fields.
There are different approaches to how to regulate your emotions, of course. I don't think suppressing is probably most effective. I think there in short term it might work best for your stress response or emotional response, let's say. But in the long term, I don't think suppression is the best approach. I'm not sure for reappraising and so here interpreting the event as more positive. If that's, I do think that's still a good strategy to teach people, and I think I just think that reappraising, I do see the merit in that. So I wouldn't say that that we're focusing on reappraisal is probably not the cause of relapse and recurrence levels. But of course, especially with my thesis now, it's a combination that probably also helps, right? So combining those techniques with stimulation might have long-term effects. Even if we see it in a single session with healthy volunteers, I still think it might be a promising approach to take.
Thank you very much, and I hand back to the chair.
Thank you for your questions. The opposition will now be continued by Professor Schreurs, who holds a chair in the mechanisms of affective disorders here at Maastricht University.
Thank you, Mr. Chairman. Dear candidate, first of all, I'm going to repeat my congratulations, which we've already done previously online in Ghent, and this time in the presence of your supervisors. I think your work is very impressive. I really admire the methodological rigor. I already said that it's clear that this was an enormous amount of work. You can see it by the printed version of the thesis is quite impressive. I think which makes for, even if perhaps at one point in time the content might be outdated, I see all kinds of practical aspects that the book can be conserved. But okay. My first question pertains to chapter 6, which is we use functional connectivity as an outcome, and I'm going to cite you. You say that priming prefrontal TBS with CTBS led to reduced connectivity changes in both regions near the stimulation site and more distal temporal areas, and priming significantly reduced connectivity changes in prefrontal regions. I would like to propose a different interpretation of the results, Stuart, which I would like you to comment on, which is that the found connectivity changes are in fact coincidental findings due to natural variation. Because the retest reliability of particularly functional connectivity is really poor. It's reasonable where if you use paradigms, for example, tackling primary motor cortex or primary sensory cortex, and you use very long acquisition times, then you get up to correlations up to 0.8. But with these paradigms and with these acquisition times, I would wonder, what would you think about that?
Highly esteemed opponent, thank you for your kind words and your question. I agree that there's a lot of variability, especially because we did it at rest, though we used a very large sample size though, especially in this setup. And we also controlled for order, so actually none of the participants did the same order. So I think doing that we can already control for what we would call merely incidental findings. And also, if it would have been other regions, random regions, then I would say perhaps. But because we find strong blobs under the coil, I do not think that's a coincidence. So I do not disagree entirely with your statement. I don't think it's a coincidence, though it does need some further look into it. Especially because it's at rest and we don't really know what it means. We measured several psychological measures related to mood and rumination, but we didn't see any differences there. So for all we know, a reduction might be more efficient. That's also an alternative explanation I've been thinking about and wondering, like, how can I, analysis-wise, untangle whether reduced connectivity might also be just more efficiency. Because stronger regions, but perhaps stronger connectivity between those.
Okay. So your point is a little bit that given the particular anatomical spread of the findings, you stick with your
Yes, and the well-controlled setting, the high sample size, doing it before and after, controlling for their baseline state. I think those are all methodological aspects we took into account to reduce the fact that findings are driven by coincidence, of course. Of course, we can never rule something out like this, but it's also within subjects. Again, increasing the likeliness that our findings are driven by changes within those participants and those simulation combinations.
Okay. I accept that. I'm glad you stick to your point. I can appreciate that. I'd like to ask your advice on another topic. You know that when you treat people, for example, for affective disorders, now we know that TMS is very effective. But there's also very effective psychological therapies. And based on some of your work, particularly the earliest chapters, one would say, okay, it would be better to give people some psychological treatment and then immediately follow that up with TMS that might be more effective. And there's research in that direction. But you could do the reverse as well. You could argue, well, because these psychological therapies are actually the most effective therapies that we have for most affective disorders. This is really what the end goal. We want to make them as effective as possible. And we want to prepare the brain state for that therapy, probably, for example, by doing neurostimulation, whatever, beforehand. So based on your work, which order would you advise?
For research, I would try to do it in a sequential order because you then can disentangle one from the other. Like we did in chapter 3, we did stress before because then we had clear stress effects that weren't affected by simulation, and then we did simulation and did working memory after. But in the clinic, I wonder if it wouldn't be more useful to do it at the same time, because you want to engage those networks, and I don't think it matters that much that you're already changing things in those networks while you stimulate them. So clinically speaking, I think it's probably most interesting to do it at the same time. I know there are some studies doing cognitive control training during TMS actually, though it's in healthy individuals again. They don't show effects on cognitive outcomes, but do see activation changes, frontoparietal activation changes. So that works in favor of simulating at the same time of doing a task.
Okay. That's a very clever answer, of course. I give you two options. You pick the one in the middle. And that is, I can follow your argument, but many of these termed psychological therapies are actually not just sitting down in a chair and talking to each other. They involve doing a lot of stuff, which is actually not possible when you're sitting still with a coil above your head. Like, for example, exposure therapy. It is by far the most effective therapy we have for most affective disorders. And you can't do that sitting still. So I think I'm afraid you'll have to choose one order for me.
Can you really not? Like, I don't know, for actual exposure therapy, true, but you could do symptom provocation during stimulation, though.
Yes, well, I'm not going to go into that, but assume.
Okay, I would do it before. I would do the therapy before the stimulation, I would say.
Why?
Because you're then already, we know with brain stimulation that it depends on the functional state of the brain. So if you're not doing anything, then what are we stimulating? But if you do the therapy before, you're activating the networks, and then hopefully if you stimulate after, these networks are still active and you're making changes in the networks you want to see. And that's also clear from what I showed in my thesis, I hope.
Can't you make the exact same point reversing this?
If you stimulate and your patients...
Changing brain states, no?
Yes, but from what we see in the final chapters, doing it at rest, so doing it before our therapy, doesn't appear very effective, and you also don't know what is going on, right? You're not activating something you're interested in. So
I would love to go on with your discussion, but I'm clearly what I should not. I'm very happy with your answer. Thank you.
It also looks like a discussion that is not going to be settled within the time that we have. So
I agree
very much for your.
There is a reception. So
And the opposition will be continued by Professor Blokland, who holds a chair in comparative neuroscience here at Maastricht University.
Thank you very much. So also my congratulations and to your team for this wonderful work, and I must say I'm impressed by the way you handled all these different data and how you analyze the data. So it's really a wonderful piece of work. But I want to continue with some questions, and I would like to go to chapter 4, where you find the effect on the cortisol levels in the high rumination group. But the high rumination group is based on a trait. So actually what you find is more like a trait dependence of the prefrontal non-invasive brain stimulation effect. So how can you align the trait versus your assumption and your focus on the brain state dependence? I don't see the match between these two, because you find the effect in the trait, not on the state.
Highly esteemed opponent, thank you for your kind words. Thank you for your question. I think traits matter as much as states because they define our states. If I'm a high ruminator and they put me in the sweat cabin before, I might have triggered a whole rumination session and activate certain networks that might also be activated when we do someone who doesn't overthink and introduce them to a stress paradigm. So in this case, for rumination, they might already have very different baseline activity that could impact your stimulation outcomes.
But how can you be sure? Did you test that?
Did we test?
Because you can have a trait high rumination, but you do not have to show always the state effect.
We did measure state rumination during the session, and we did see that those high ruminators those show a typical pattern which we often see in the literature with increased stress reactivity, increased state rumination in response to the stressor compared to the group with lower levels of rumination. So we could confirm that in our study those high threat ruminators will actually also state-wise reacting differently.
Did you check whether the high rumination also have the strongest response? Is a correlation between high rumination and a higher effect on the state?
You mean the correlation between their...
So if you're a high rumination person, would you have also the strongest effect on the state?
I don't think we checked for correlations, but if...
That would make the correlation between trait and state, as you proposed.
It's not in the chapter for sure. I don't know if we checked it, but I suppose there will be a strong correlation. There is so in the literature. I would have to check. I brought my computer, but...
No. Probably there is some kind of relation, I will agree. With respect to the cortisol, you tested participants between 12:30 until 5. And you know you're in the descending phase of the daily cortisol fluctuations. So did you check for that change, and does it affect the data to some extent? Did you check for that in some way?
Yeah, so we tried to control that between the conditions, that they all came at similar times, and we did see that there was no significant differences. So the time of day that they came in wasn't related to the effects we saw. So I think that confirms that it didn't affect any of the outcomes.
Okay, yeah, that's good. Yeah, I had some other questions, but now when having these discussions, as in the back of my mind, I always the question. So my proposition would be it will be impossible to find optimal brain stimulation parameters for an individual for treatment, because we have different brain states. We don't know what brain states will have an effect. You only affected some psychological and physiological state conditions. Then we have different networks that we can activate or deactivate. Then we have different stimulation parameters. We have different stimulation protocols, stimulation methods. So I don't know where to start to find, and we also talked about biomarkers for maybe if you have this high heart rate variability, maybe you more. So I see too many degrees of freedom to go to an individual and say, okay, we need this kind of stimulation protocol to treat you. And even maybe with a combination of CBT. So how do you see, so for me, my point of view is I don't see a future where you can use an individualized stimulation protocol for an individual patient. Do you have a more positive, optimistic view on this?
I'm afraid we have to start somewhere. So there's a and I think that's the case for all types of parameter space in terms of brain stimulation. Although state dependency is less well explored. Like if you look at the field, they often check location at DLPFC, orbitofrontal. Do we do functional guided connectivity targeting? That's also, I imagine at the beginning of that also looked like a whole bunch of work where they didn't see the end of it. And I think with context or state, it's less well explored, and we have to start somewhere. So I think already implementing it more in research, but also in the clinic, there are rarely clinicians that do something with states or traits during stimulation whatsoever now. I think there are almost none.
Because it's too complex. And then you get further away from this.
Perhaps because it's still something that needs to be conferred more over and over. And I wonder where we are at 10 years from now. I mean, we have to start somewhere. By doing something, doing a task versus rest, we can already try to reduce variability on a group level, and we can then further tailor this further and further into individuals. I understand it's a huge job, and it's something that will take a lot of work, but I think every step in the way is getting us a bit closer. So
thank you. Good to hear that you're more optimistic than I'm currently in this state of my mind. I'll give the word back to the program.
Thank you, Professor Blokland. The exposition will now be continued by Professor Lisette, who has expertise in cognition and non-invasive brain stimulation. The floor is yours.
Dear candidates, I would also like to extend my congratulations to you and your promotion team for excellent collection of studies. And as the others have already pointed out, I think it stands out. The huge sample sizes and the amount of work that went into this is really impressive. My questions are a bit focused on the neurophysiological side of the stimulation, particularly the ITBS or the CTBS. In your thesis, you cite a few times the study from McCallie from 2001, where in the motor cortex they applied both CTBS and ITBS in the same participants, even using different number of pulses. And actually, it's a very discouraging message that they have, because it goes all over the place. CTBS is supposed to be inhibitory, but the MMPs are sometimes higher, sometimes lower. I guess the only positive news from the paper is that usually something happens, right? We do something. but it's definitely not consistent in which direction it goes. So, drawing from this, I wonder how you look now at its priming effects, because if it's not consistent what one of them does, like how do you expect them to interact, and how do you expect to get a grip on this, that you don't just mix it up in all kinds of directions in your participants?
Esteemed opponents, thank you for your kind words and your question. And I certainly agree. That paper did give me a big head scratch because we were, in general, most of our simulation parameters when we're talking about pulses and these kind of things are based on motor cortex studies, which I wonder in which way they also translate to prefrontal cortex. Unfortunately, in motor cortex, it's easier to have concrete evidence. Besides with prefrontal cortex simulation, your effects could depend on the task you use. So I wonder there how motor cortex findings translate to prefrontal cortex findings, and especially with the priming, because we had the number of pulses, but also the time in between, doing it at the same time, yes or no. And yeah, it does feel a bit like, where do we continue from here? Though based on recurrent literature on these intervals, I think that's an interesting step to take and to continue with, like how that matters. But again, like with the CTBS, depending on the number of pulses, whether it's inhibitory or excitatory, we don't know. And from our findings, I'm afraid we didn't become any smarter there too. So yeah.
So you already mentioned it, right? This translation from the motor cortex to the prefrontal cortex is not necessarily evident, right? The composition of the neurons in these locations might be quite different. So if you would have to think about what kind of marker you would like to have to demonstrate that your stimulation was indeed increasing excitability or decreasing excitability, what kind of marker would you think about? What could we implement? What could we try to do?
With a lot of budgets, I would put them in the scanner over and over again. But also, that doesn't have a...
Why are you bothering?
I must think or something, yeah. Oh, and this is on YouTube. Wacht, what was I saying? What
kind of marker would you aim?
Yeah. So we need target engagement, we need something to... so I think putting them on the scanner would be nice to see target engagement, although I do think like the outcomes we used, working memory but also stress, are important measures we can keep implementing, though there the problem again is if we don't find anything, is it then related to not being stimulated more efficiently, or yeah.
All right, good. Maybe a little bit on similar lines, but in chapter 5 you decided to give this TDCS and ITBS at the same time, right?
Yeah.
So I was wondering a little bit about the neurobiological rationale for why would you combine them, and also did you think about how maybe those electrical fields would interact, and what would this do to each other? Like how would it actually lead to accumulating effect rather than disruptive?
Yeah. At the time when we did the study, I don't think we were hypothesizing about how electrical fields might interact to each other. What we did consider a lot was like co-activation, functional targeting. Like similarly, if you do a certain paradigm and activate the networks, you were thinking that with TDCS stimulation we would activate the networks, and then these networks were already activated, and then with the magnetic stimulation we would boost them. So that was the idea, a bit probably an oversimplification, but that was the reasoning behind that.
So the results there were fairly inconclusive, right? So is this something that you would try again, or would you try to do them sequentially if you would do it?
Yeah, I think doing them together was complicated for various reasons, and also related to the discomfort. So the stimulation might already make the place more sensitive, and ITBS stimulation, as you know, is already not very comfortable. So I wouldn't advise doing the combination again, especially because of that discomfort, but also untangling of effects, like the fields you mentioned. And also, if you can consider the literature about leaving more time in between to let these plasticity effects occur, I don't think that stimulating at the same time would be a road I would take in the future.
With my eye on the time, I will change my last question. And actually, I would like your advice, right? Similar to what we've had before. So you've tried different ways of doing the designs. In a few chapters, you've done the between subject design, still very high sample sizes, but the same participants did not receive the same type of stimulation. And later you, I don't even know if how they were actually performed in time, but in the other chapters you went for a within subject design. So what would you now recommend, right? If I would want to compare different stimulation paradigms, how do I best go about this? Would you advise me to go for a between subject or within subject design?
I know there are strong opinions about that, and trying to not get. But if you do the stress studies, I'm afraid.
Ora est.
You can briefly finish your answer.
Yes. If you do stress paradigms, I'm afraid between subject studies are more appropriate. It's really difficult to repeat stress paradigms that don't show habituation. So for that reason, between.
Thank you. Stefanie De Smet, the time appointed for defending your thesis has passed. The degree committee will now discuss the quality of your thesis and your defense. In the present context, I will request that you and your company leave this room, and after the deliberation, the beetle will bring you back, and so you will all return to this room to hear the verdict of our deliberations.
All rise, please. Please be seated.
Stefanie De Smet, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Zak is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor, Professor Zak, to take the floor.
All rise, please.
Belooft u dat u altijd volgens de beginselen van wetenschappelijke integriteit te werk zult gaan, eerlijk en zorgvuldig, transparant, onafhankelijk en verantwoordelijk?
Ik beloof het.
Krachtens de bevoegdheid ons door de wet toegekend, volgens het besluit van de commissie hier tegenwoordig, verklaar ik hierbij u, Stefanie Norbert Lisette De Smet, tot dokter te bevorderen en u alle rechten te verlenen die daaraan volgens wet en gewoonte zijn verbonden. Ten bewijze hiervan overhandig ik u nu de bul door rector, secretaris en overige leden van de promotiecommissie ondertekend en met het grootzegel van de universiteit bevestigd.
Please be seated.
Dear Stefanie, before I give the word to Marianne, of course, your main supervisor, who will give a laudatio that I'm sure will be wonderful, I would just like to say a few words also on behalf of me, my group, and Maastricht University. First of all, thank you very much for the last years of this cooperation. I remember vividly when we first met and we had this crazy idea, maybe state dependency is also something we are very interested in here in Maastricht, and you focus on this topic in this world famous lab in Ghent with Marianne and Chris, where we also have other forms of cooperation for many years already. So we thought, like, can't we set up such a double PhD ceremony and degree, and you were up for it, and I would like to really thank Chris and Marianne that they also facilitated this from the very beginning, and of course all the credits for your work that has been praised here rightfully, the amount of work, the quality of work, all the credits have to go to Ghent, to Marianne and Chris for supervising such a talented students. So I had the pleasure to be a very small part of this journey. But I have to echo what has been said here before. I'm really impressed, so is my group, from you as a researcher, as a talented researcher, but also as a person. You came like a hurricane into our lab, immediately understood the group dynamics, took over, organized meetings of groups that I thought, like, this is a good idea, we should have done that for a long time already. You saw that there's a need for going more into the fMRI analysis, different connectivity pipelines. You gathered around in our department the people interested and organized those meetings, things like this. Absolutely amazing. And your level of dedication and also interest to the field is also shown on a national and international level. I've never met a PhD student, you're finished now, you're now Dr. De Smet, but as a PhD student you're already so mature and you play an important role in in the Brain Stimulation Foundation, the Flemish Dutch Brain Stimulation Foundation, the ESBS, the European Society for Brain Stimulation. You're taking on these responsibilities and you help the community forward with your energy and with your great organizational skills. So highly, highly impressive, and thank you very much for everything that you've done. And I'm sure you will do in the next years, because you have also, of course, because of your talent, got quite a competitive research grant, and you will continue in academia as a postdoc, and hopefully also we can continue our collaboration. So thanks again, thanks to Chris and Marianne, and now I give the word to your main supervisor, Marianne, for the laudatio. Here. As you wish.
Oké. Beste dokter De Smet, ik ga het in het Nederlands doen, dat kan uw familie ook volgen, hè, met de laudatio. Lieve Stefanie. Vandaag is zo'n moment waarop je als promotor probeert de juiste woorden te vinden voor alles wat je de afgelopen jaren voor ons schepteam, maar ook voor mij persoonlijk, hebt betekend. En ik spreek hier vandaag in naam van jouw ook promotor, professor Sak, en co-promotor ook, professor Baken. Vanaf dag 1 maakte je indruk. Een orkaan is eigenlijk misschien wel een goed woord om te vertellen. En toen je in 2018 als stagiaire in ons scheplab-team startte, dan maakte je meteen indruk. En weet je nog, door onvoorziene omstandigheden liet ik je toen, weliswaar niet te lang, maar alleen achter in de bureau met 2 zwaargewichten in de neuromodulatiewereld, professor Baken en professor Brunoni. Jouw taak? Een onderzoeksproject vormgeven. Ik weet toen dat je heel onzeker was en ik begrijp dat. Maar ik had er alle vertrouwen in en niet zonder reden. Dat project dat je toen bedacht had, samen met professor Baken en professor Brunoni, werd uiteindelijk toegekend via een bilateraal FVO-fonds. En zo kon jij starten met je doctoraat. En later haalde je ook nog je eigen FVO-aspirantschap binnen. Een prestigieuze beurs die slechts weggelegd is voor een zeldzame groep van jonge onderzoekers die zich echt weten te onderscheiden. En dat verhaal, eigenlijk in het bureau en zelf je onderzoeksproject bedenken en dan een project binnenhalen, een FVO-aspirantschap, dat deed me denken aan een doctoraatstudent die op heel veel vlakken de enige was. Een uitzondering was. En ik wil eigenlijk graag stilstaan bij het feit dat jij keer op keer behoort tot die zeldzame groep van onderzoekers die grenzen willen verleggen om een verschil te maken. En niet alleen in de wetenschap, maar ook om de mensen, bij de mensen rondom jou. Jij bent bijvoorbeeld de enige PhD-student die alle neuromodulatietechnieken in ons labo heeft aangeraakt in haar doctoraatsonderzoek. Je werkte met TDCS, TVNS, RTMS, ITBS, CTBS. Je gebruikte verschillende apparaten voor psychofysiologie te meten, om autonoom zenuwstelsel. Je rapporteerde cortisolanalyses. Je gebruikte diverse stressinductiemethodes zoals de trier en de mast. En toen bleek je nog een passie voor fMRI te hebben. Dus stelde je een studie op met ITBS en MRI. Ik ben er zeker van. Jij bent een van de weinigen die al die kennis binnen 1 doctoraatstraject heeft weten te verzamelen. Jij bent ook de enige die een complex fMRI-design heeft uitgedacht met 3 condities. 3 emoties en 4 primingscondities. Dus 4 scanningssessies per persoon, within subject. Ik herinner me nog levendig de labmeeting in januari 2021, voor de start van jouw studie. We keken met open ogen naar jouw design dat je voorstelde. Maar jij beet je vast. Weekends, avonden, feestdagen, jij was aan het scannen. En zelfs toen de ITBS-spinnen doorbrandden, weet je nog, je hebt mij gebeld zo, op een vrijdagavond, net voor het weekend, een feestdag, dan ben je doorgegaan. Je kreeg een paniektelefoontje, maar je hebt het toch opgelost en dan je bleef doorgaan. Maar naast dat onderzoek ben jij ook de enige die een podcast over wetenschapscommunicatie maakte op de Dag van de Wetenschap. Je interviewde verschillende wetenschappers over uiteenlopende neuromodulatietechnieken met een aanstekelijk enthousiasme. En dat in coronatijd waarin veel PhD-studenten juist de moed verloren. Wetenschapscommunicatie vond je dan ook belangrijk. Jij was en bent enorm gedreven en steeds op zoek naar de juiste balans tussen wetenschappelijke impact en maatschappelijke relevantie. Je stelde me vaak kritische vragen over je eigen academisch traject, maar ook over het bredere academische systeem. En je stelde die vragen al van in het begin. van je academisch traject. Want je wilde niet liever dan te blijven behoren tot die kleine groep van onderzoekers die ook echt een verschil maken. En je maakt een verschil. Jij bent ook, Stefanie, de enige PhD-student die me onverwachts opbelde terwijl ik in de auto zat op een vrijdagochtend. Marianne, ik was gisteren op een bijeenkomst en daar zag ik professor Sak. En ik denk aan een joint PhD met Maastricht University. Wat denk je? Nu, ik weet nog dat ik toen de auto aan de kant heb moeten zetten om dat te laten bezinken. En je vertelde over al je enthousiasme over professor Sak, over de mogelijkheden die je zag, maar ook over je twijfels. Zou het haalbaar zijn? Gaat dit niet te veel worden? Maar al snel bleek, als iemand het kon, dan was jij het wel. En zo geschiedde. Nog voor ik het goed en wel besefte, lag er een joint PhD-overeenkomst op tafel en pendelde je regelmatig naar Maastricht. Jij was opnieuw één van die uitzonderlijke promovendi die de kans kregen om deel uit te maken van de Research Group Brain Stimulation and Cognition van Maastricht Imaging Center onder leiding van professor Zak en professor Schumann. Dank u wel daarvoor. Maar jij bent ook voor mij de enige die op een dag begon met ik ga een bommetje gooien. Ik ben zwanger. Daarna trotseerde je extreme misselijkheid. Overwon je vermoeidheid, organiseerde je zelfs tijdens je zwangerschapsverlof nog een BNE-congres en schreef je nog eens een FVO-postdoc-project uit. Om dan terug te keren uit je zwangerschapsverlof met een prachtige baby Celeste die er al was, en te beseffen dat je doctoraat dan binnen enkele weken moest ingediend worden. Ik denk niet dat veel mensen of veel doctoraatstudenten dit zouden nadoen. Je slaagde erin. En opnieuw behorend tot die kleine groep van onderzoekers die zo'n fel begeerde FVO-postdocbeurs weet binnen te halen. Jij bent ook de enige die in 1 week tijd je doctoraatsthesis finaliseerde, een artikel submitte, een interview gaf voor een FVO-postdocbeurs en meewerkte aan een TBM-project. Ik vermoed eerlijk gezegd dat je daar nog van aan het recupereren bent. Maar Stefanie, jij maakt niet alleen een verschil door hard te werken en wetenschappelijk te pionieren. Jij was ook een collega met een groot en warm hart, die zo een verschil maakt voor de mensen rondom jou. Je stond klaar voor stagiairs, voor collega's die het moeilijk hadden. Jij was degene die nog een kaartje regelde voor collega's, een geschenk organiseerde voor iemand die net zijn doctoraat verdedigd had. Je stond er ook voor mij, Stefanie. Je hielp achter de schermen bij Calmwaas, weet je nog hoe zenuwachtig dat ik daarvoor was? Je luisterde, je dacht mee, je bood steun als het nodig was. Jij bent voor mij de voorbije jaren een onmisbare steunpilaar geweest. En daarmee maakte jij voor mij echt een verschil. Ik ben ontzettend dankbaar voor je werk, voor je inzet, voor je loyaliteit, maar vooral voor je menselijkheid. Voor de keren dat je zei, Marianne, ik neem het wel over. Wat kan ik doen? Hoe kan ik jou helpen? Ja, en soms liet je ook eens een traan tijdens een teammeeting. Bijvoorbeeld bij een foto van Vienna na de sterilisatie.
Ik was zwanger.
We konden ook praten over onze hobby's, onze tuin. Ondertussen begon je met possenbakken. Je man Jonas, baby Celeste, je ouders, je zus, je honden kwamen regelmatig voor in onze gesprekken. En ook je paranimfen, Matthias, Sarah. We hebben een heel leuk team, we hebben heel leuke gesprekken gehad. En daarvoor wil ik iedereen van harte bedanken. En het mooie is, dit is geen afscheid. We blijven samenwerken. En ik weet nog niet of dat jij je nog herinnert, maar aan het begin van je doctoraat, na je stage in ons scheptap, dan vroeg je aan mij, zie je het nog zitten om 4 jaar met mij samen te werken? En ik ben daar toen snel overheen gegaan, maar die vraag is wel in mijn hoofd blijven hangen. En nu wil ik die eigenlijk volmondig beantwoorden. Ja, Stefanie, natuurlijk, met heel veel goesting, zoals ze in Vlaanderen zeggen. Jij was, jij bent en jij blijft iemand die altijd dat stapje verder gaat. Een van die zeldzame mensen die het verschil maken. En ik ben heel blij dat wij nog lang kunnen blijven samenwerken. Jouw fiere promotor.
Dank je.
I will switch back to English. So, dear Dr. De Smet, also on behalf of Maastricht University, I would like to congratulate you with the degree that you earned today. I would also like to thank the entire committee here present, especially also those who come from far and have joined online, for all the nice questions that were dealt with so excellently by Dr. De Smet. I would like to thank the audience, the family, the friends, the husband. I don't know if I should thank the baby as well, but I think it's probably proper to thank everybody in this room. Before I end this ceremony, there will be a reception, there will be some pictures. We will take pictures here. I don't know if there's somebody assigned to this task, so there will be pictures with you in the paronyms and everybody in the robes, and then after that we will also take some pictures outside on the staircase, again with us but also with the family. Yeah, I think that's probably it. So I hereby close this ceremony.
All rise, please.